Maybe you can get started. Good morning. So I'm very excited to welcome Dr. Nilam Soni. He's a professor of medicine at San Antonio. He trained most of us for focus and very well known nationally. So he is the national director of the Society of Hospital Medicine certificate program. He also received numerous national awards for research and service. He also delivered a lot of ultrasound workshop. He is a disclosure, my mentor in focus as well. Floor is yours.
Thanks, Huzam. Good morning, everybody. For those of you that are online, can you hear me okay? I can't see the chat.
Yes, we can.
I'm just if you have questions or comments, please put them in the chat. We can go through them at the end. I'm going to try to finish up with about 10 or 15 minutes for discussion. So first and foremost, thank you. Thank you for the invitation. I love this weather. They thought I was joking last night at dinner. I said, this is great, 55 degrees and moist and rain. I mean, we went from cool to 105, 110 overnight, and I don't know what happened. So great weather and the warm welcome. So we're going to talk today about point of care ultrasound. This is a fun topic. It's been the passion of my work. You know, Hussam says all these different accolades. At the end of the day, I'm a clinician. I love clinical work. I used to work as a nocturnist when my kids were small, and that's actually how I got into point of care ultrasound. Daytime hospital versus nighttime hospital, day and night, literally, right? At night, you're there, you're by yourself, you don't got all the services, and I'll talk a little bit more about that. As far as disclosures go, the only disclosure I have is that I am biased towards point of care ultrasound. I don't work for any of these ultrasound companies. I'll try to use generic words like handhelds, but some of these companies have like proprietary software and things which I might mention. I had some VA grants. Those are actually going away, but still going to keep doing lots and lots of POCUS. So I'm going to talk a little bit about the evolution of POCUS and ultrasound technology, and then talk really, hopefully have a little bit for everybody. We've got residents and trainees, faculty of all ages. So there's a little bit of clinical, a little bit of administrative, and then, you know, some nice cases. And then talk a little bit about the future of POCUS and where we're going. So ultrasound machines, this is what they look like about 100 years ago, maybe 75 years ago. They were big, they were bulky. You can see that these individuals here are in water baths. So we still use water today, or we have gel, but we could still use water in certain cases. And then in 1965, the Siemens Vitason came around. It was the first real-time scanner, meaning prior to that, you'd get still images. So to look at heart contractions, they would have to splay out the images on the wall of systole and diastole, and the interpreter had to try to recreate this in their mind and figure out what was happening to the heart. We just got that in 1965, and then in the 70s, the first standard of care exam came around, obstetric ultrasound. This is a nice video. You can see this. This is actually a pregnant woman. This is in Australia, 1967. She's in a bath of water, and there's this echoscope going around her. And if you pull this up on YouTube, you know, the conversations here from 1967 are a lot of the same conversations we have today, where people ask, well, how do you know this is safe, and how are you going to use it, and what can you do with it? And it's interesting to hear the obstetricians' responses, because they're very similar to what we had now. And that's what the image looked like. Not the prettiest image, right? We've gotten spoiled having nice images. And look at the question. He said, why don't we use this on all pregnant women, right? Sort of the same question we're asking now. Why are we not using this on all or most of our patients? So that technology is now become portable, very portable, ultra portable, growing faster than we know what to do with it. Portable. There are devices that are handhelds that can connect to your phone, that can connect to iPads, that can connect to Androids. There's lots and lots of devices, a huge market. So that large cart-based technology has now been made into these portable cart-based systems down to these handhelds. And this handheld market, got one more slide with handhelds, has just exploded. Like I said, we did a comparison in January 2024 of 6 different handhelds, and it's published out there. By the time it was published, it was already updated because there were so many software updates. We actually need to repeat that in the next year or so, because everybody asks the question, which one should I buy? And we're trying to make a more objective evaluation of them. Some of them are wired, some of them are wireless. Bottom line, technology is getting better and better and more powerful. These are actually more powerful than some of those big machines I showed you from 1960s and 70s. So you have that technology now in your hands. It's just up to us how we're going to use it and what's the best way to use it. If you go to Google, our favorite search engine, right? Go to Google, put in portable ultrasound, you'll get pages and pages of these. Every time I do it, it's kind of fun. There's Eagle View. I've never used an Eagle View. It's a new brand. There's so many different brands that have come up, some that are not available in the US. And then, if you look at the price point up here, these are all handhelds. They're about 1,500 to 3,000, maybe 4,000 range. So that's kind of where the prices settle, between 1 to 3, 1 to 5,000. So the technology's come a long way. What about our integration in medical specialties? So you can see that here, going back to the 60s and 70s, the early adopters, cardiology, obstetrics, then emergency medicine, critical care, trauma with the FAST exam. And we're on this steep part of the slope now where pretty much every specialty is integrating it. And at the very top, may make some of you uncomfortable, but can patients use POCUS? They're already doing it. There's certain things that we don't like because they make us uncomfortable, but the train is already left and it's going pretty fast. So I'll talk a little bit about this. Key points here: technology is advancing rapidly, and then everybody has access now to machines. And we're going to need to have a working knowledge of this, especially for teaching institutions, for faculty, to supervise residents, trainees. I'll tell you, most of the time, the residents, the fellows are right. They are very adept at doing these exams, and the faculty are uncomfortable because historically we haven't taught ultrasound even in medical school, right? We pull up the x-ray, we pull up the CT scan, and we'll go through the cuts. How many of you open up the ultrasound exams, right? It's probably, some of you probably do now, but most of the time it's like, oh yeah, we don't go there. We don't click that one. We'll just read the report. After some basic POCUS education, you'll have a working knowledge of how to look at ultrasound images. And I think I would recommend you do look at those images that radiology or cardiology is gathering. 2 reasons. One, you'll appreciate how hard their job is because they get usually one still image and they've got to put their medical license and their reputation on the line. They got to make a call, which is why you may see some hedging, possibly consider, because they get an image, they never see the patient, or rarely would they see the patient. And then they don't have the clinical picture, right? So on your requisitions, put in there what you're looking for. Be as specific as you can. That'll help them. Because if you're looking at the entire chest in a CT scan versus, hey, we're worried about this pain down by the diaphragm in the right claustrophrenic recess, then they can focus in on that area. So how are we using ultrasound now? What are the definitions for POCUS? So key points here. These are goal-directed exams, and ultrasound is being used for diagnostic exams and for procedures, typically bedside procedures. And I think the other key point here is that this is done by a healthcare provider or a clinician. So not an imaging specialist, but somebody who's actually making clinical decisions for the patient. This is kind of a nice slide on the spectrum of ultrasound exams that we have now. So we have our classic comprehensive exams, right? The diagnostician says, hey, I need to get a right upper quadrant ultrasound, puts a requisition in, transportation takes them down to radiology, sonographer images them, goes into the PACS, radiology reads it, prepares a report, somebody transcribes a report maybe, and then it gets back to the diagnostician. Many, many steps, some delay, higher costs, but a comprehensive exam of an anatomical region. In the middle, we have these limited exams, and there are billing codes for these, and I'll show these to you later. This is where you do a more focused exam, and this is where most point-of-care ultrasound exams are falling if you're archiving and billing as a documented exam. So they're focused, you are archiving images, making a report, probably billing, should be billing if you want to, if you're doing these exams and you've been credentialed. They're quicker, and then there's some revenue it'll generate. All the places that have started billing and formalizing POCUS use say, wow, this actually is a fair amount of money. And it's not that you're going to make millions and millions of dollars doing point-of-care ultrasound exams. The bigger benefit is for the system and reducing complications and getting patients through the system. So as a bigger picture, we save money. But this can help justify the equipment you need. It can help show the usage, right? And that can then help make the argument to the system that, hey, we're using this and we need new machines, or we need to invest in people's time for training. And then there's this category here, extension of physical exam. So for my emergency medicine colleagues, this may make you cringe. In the early days of point-of-care ultrasound use, Our emergency medicine colleagues had to really fight to get recognized through from radiology and cardiology that no, we are qualified, we can do these exams. It's not a part of the bedside exam, it's a separate diagnostic exam. With the explosion of handhelds we have, this category is actually growing quite a bit, where somebody takes a quick look, gets the basic data they need, and they move on. And the reason they're not archiving is because their device is not compatible with the system. They're not approved to be on the network, whatever it may be, or it's an emergency situation and someone's like, oh, I forgot to save the image. They're already wheeling them off to surgery. You know, we did the triage, or it's a code situation and somebody forgets and you're just trying to take care of the patient. So this, you know, as much as we don't want to have this, maybe people don't want to have it, it's being used and it's going to continue to be used like part of the bedside exam. So why is POCUS use increasing? First and foremost, the devices are now available. They're everywhere. I think you have a really good fleet of ultrasounds available even on the floors, and there's lots of handhelds. And then from a health system, hospital standpoint, if one procedural complication will pay for at least 1 or 2 machines. And so if you can reduce even 1 complication per year, that justifies the machines. And this is pretty basic. This is, you know, bedside procedures we do all the time. Healthcare providers, we're all compulsive. None of us want to be the one missing the obvious. Nobody wants to get that call. Hey, why didn't you call us sooner? You know, how did you guys miss this? Well, it's obvious in hindsight, but when the patient came, it wasn't. Well, we can drop that miss rate. That can be 0, but we can make it better than what we are at status quo. There's an expectation for perfection. Not only do we want to be perfect, everybody wants to be perfect. Our scores are on the internet, hospital ratings are on the internet. You know, the hospital administration wants to be perfect. So we need better tools. Think about it, right? You come to the ER, you come to the hospital, come to the clinic, and you're scared. You don't know what's going on with your body. And what kind of tools do we have our providers equipped with? Our hands. By the way, your sensation goes down after you've passed your mid-30s. Your stethoscope, our hearing also starts to go down after mid-30s. Percussing, like, do you want me to come and percuss your abdomen? Well, I'm gonna make a major decision for your well-being and your care. So we need better tools. And the last one here I want to mention is improve patient-provider experience. Not only is it beneficial for the patients, it's also beneficial for the providers, right? We talk about burnout. It's a hard job. Clinical medicine is a hard job. Well, we're putting up our clinicians against a hard job and not giving them great tools. They need better tools, right? I mean, everybody carries one of these things. You can send money around the world. You can WhatsApp with somebody on this side of the world, but why are we stuck in this time, in this era where we say, oh, no, we still want you to percuss the chest when we got better tools available? I think it's a balance. I think people need to know some of those traditional physical exam skills, but if you only have a finite amount of resources, some of that needs to be dedicated towards point of care ultrasound training, better tools, and also just understanding imaging in general. And then it's a source of clinical revenue. Like I mentioned before, once you start billing, all the institutions, everybody I've talked to says, wow, we actually were not capturing a lot of revenue. Benefits of POCUS for procedures and diagnostics. Procedures is pretty straightforward. This is all this major thoras, paras, central lines for sure, fewer complications, higher success rates. And then on the diagnostic side, a little bit more on the romantic side, you can reduce costs, get people through the system quicker, reduce length of stay. There is literature around this, not large multi-system studies, but single institution, single unit studies. And then you can reduce diagnostic testing. That's improving the throughput. And then I want to go back to this, improving the patient provider experience, because this is really important. When people say, well, why do you use ultrasound? Because I sleep better at night, right? I leave the hospital probably later. I think my rounds and my time at the bedside takes longer. The patients feel more fulfilled. Your satisfaction scores will go up. Anything you do that puts clinicians at the bedside improves patient satisfaction scores. But at least I know, okay, there's nothing major that I missed in this patient that we're not sure what's going on with. And we can still do our workup, but I can leave more satisfied. So there's some literature around this, and I put some of the references here. So for clinicians, they have a higher confidence in decisions they're making, and then potentially reducing medical legal risk. This question comes up a lot. Our minds automatically say, what about the medical legal risk? Are you allowed to do this? What about that little nodule you may have missed somewhere? Well, when do patients sue? It gets in the whole psychology of lawsuits. People sue when they're angry, when they feel that the system didn't treat them right. And we brought my dad in and it took forever. And then he coded in the ER in the waiting room and I don't know, people are upset, right? Well, here, you go to the bedside, you do your scan, you qualify with, hey, I'm going to take a quick look to make sure there's nothing major or urgent, emergent that we need to look at. And let's take a look, right? Because we've been missing these things all along. In the reviews that they've done, the lawsuits that were there related to ultrasound were actually due to AAA's rupturing, right? Because there was a delay. They brought them into the system and took forever to get a CAT scan or whatever scan they were going to do. And so there's very few ultrasound related lawsuits, but it's interesting because it's often the delay that led to that lawsuit. That's why ultrasound was involved. And then, like I mentioned, patients like having us at the bedside. They want to see people. They want to talk to somebody. So you can be doing this to be efficient. You can be doing all this in one. While you're getting your history, you can start scanning them. So tell me about your shortness of breath. When did it start? How about this? How about that? And you could be looking at them at the same time, just to go quickly. A lot of these studies have been done in the emergency medicine setting, but last one I want to mention here is reduced radiation exposure. So now patients, family members, parents are more aware of radiation exposure. And I put a couple of slides in here about radiation exposure. How much radiation do you get from CAT scans? What do you think? How much radiation do you think you get from CT abdomen and pelvis? It's IBD patients coming in, abdominal pain. Let's just scan them, right? I mean, come on, let's just put them through the scanner. What's the big deal? How much do you think? How many X-ray equivalents do you think it is? Anybody want to guess? 500. It's about 500 abdomen, 500 pelvis. Do you need both? Do you want abdomen and pelvis? So now the lower radiation protocols are like 800, 600. So imagine being in front of the X-ray machine, pressing that button 600, 800 times. That's how much radiation you got. And then you ask yourself, how many times does it change our management? Sometimes it does. How many times does it not change our management? Okay, yeah, you have partial small bowel obstruction. You've had this before, NG2, bowel arrest, et cetera, consult surgery. But do we really need to do that, right? So if you go, here's some of the common exams that we order. This is in millisieverts, but I think that what rings with us is how many X-ray equivalents is it? And if you want, just for fun, you can go to myxrayrisk.com, calculate your own lifetime risk.
Come on, Kyra.
How many CT scans you've had. Even one CTPE protocol, they've done studies where they've looked at DNA of cell lysis, and they've talked about, does that increase women's breast cancer risk over their lifetime if they're going to live to 80, 90 years old? And there's a small fraction, but there's a fraction. So we just need to be more aware of, cognizant of the fact that too much radiation exposure is not good. We do order a lot of tests. I think a lot of that's driven, unfortunately, by medical legal risk and scare that we have. But if we can get our answer with a lower level modality like ultrasound, we get our answer and we move forward. Right? So switching gears, a little more clinical here. What are some of the more common POCUS applications? So there's a wide variety of diagnostic applications. Are you going to become an expert in all of these things? No, it's going to depend on your practice, right? So for me, as an inpatient doctor, as a hospitalist, musculoskeletal ultrasound, I love musculoskeletal ultrasound. I love my rheumatology colleagues that can do it, that they can monitor rheumatoid arthritis and these diseases over months to years in their clinic. That's pretty cool, but I don't do that, right? So I'm never going to become a rheumatoid arthritis specialist. But what I can find is I can find gross abnormalities, big effusions in joints, fractures, tendon ruptures, things like that. So my skill set in MSK is not very deep, but I do a lot of cardiac and lung because that's a lot of acute reasons why people come into the hospital. So your skill set will vary based on what you see a lot of. So when you try to narrow this down to what are some of the must-know diagnostic applications, it actually gets kind of long. Heart, lung, abdomen, all of these things you can do. And there's literature around these where they took novice users, put them through some kind of training course, and then showed that their diagnostic accuracy was good. Similar or as good maybe as sonographers and imaging specialists with certain caveats. So one workshop, you should be able to find a large pericardial effusion. That should be nobody should die of a pericardial tamponade if they present to the healthcare system, even to paramedics nowadays. But more subtle abnormalities would take more practice, more knowledge. But some of the very basic, all of you, everybody should be able to detect, including nurses, PAs, nurse practitioners, et cetera. So if you had to narrow this down to what do you really need to know? Like if I just had to know a few things, fluid in the belly, fluid in the chest, DVTs, really high diagnostic accuracy. EM studies from emergency medicine residents in their second year put through a 2, 3, 4 hour workshop. And then after that, their diagnostic accuracies are 95% and higher. So, that's something you can learn and it can change your management. Pericardial effusions and then gross LV systolic dysfunction. And then with that comes the procedures. So for those of you that do procedures, this can help your diagnostic decision-making. And this is really important for throughput. I think some of you may say, well, I don't do drainage procedures. Well, you refer them to IR and you go to how many patients you send to IR and IR says there's not enough fluid to tap. We're not going to tap it, right? So that was a delay of half a day or maybe a day or two to get them down there even for that. This is another good question. Is POCUS the standard of care? What do you think? So like, the legal definition of standards of care, it's similarly trained clinician in a similar situation, would they have done what you did? So you could make the argument for vascular access, 2002, 2001, so about 25 years ago, it came out in all the guidelines, CDC, Institute of Medicine, et cetera, all the safety organizations said, if you're going to be putting IG central lines, you need to use ultrasound guidance. Okay, so if you have a bad complication and it's not an urgent emergent situation, even in those situations, it'd be hard to argue why you didn't use ultrasound, especially because we have so many machines now that are available. What about these other procedures, Thors and Paris? Yeah, you could make a pretty good argument to say, well, why did you not use ultrasound? You should have, right? And I'll talk a little bit about Paris because that's a common one, but having the data really helps. But you can make the argument for standard of care for really any of these exams. Pick any one of them. How about skin and soft tissues? So patient had a red hot tender area, looked like an abscess. We cut into it, we cut into a vessel, and patient bled out. They were on anticoagulation. They had a complication there, So should we have looked before we cut and poked? Yeah. That's another one. I think it's a great example of abscesses, right? We've been saying for generations, come on, don't be a wimp, just cut into it. But like you ask, well, if that were your leg or your thigh or your abdomen, do you want me to just cut into it and then come and say, hey, sorry, sir, we thought you had pus in there, but you didn't. Just kind of pack it, I'll give you some pain meds and you're going to be left with a scar. And maybe we didn't need to do that, right? So we've been saying that for generations, but Matt, we should look before we poke or before we stick, have more data. I didn't put any pictures in there, but we have, we've seen some abscess pockets and then there's a vessel hiding right there, little arterial branches on it. Well, now you can avoid that. You're not just going in blindly. Or you can say it's a big abscess and you say, wow, I'm not going to do this at the bedside. We need to call surgery or somebody else to come and take him to the OR. So some of you might say, well, I've been doing this for a long time. Do I really need this gadget? Well, literally and figuratively, you don't know what you've been missing all this time. So let's take something common, big bellies. Differential diagnosis for a big belly. Could be ascites. What else could it be? This could just be a big belly. They've got good food, right? So could be adipose. What else? Cirrhotics. They get abdominal wall edema. It's abdominal wall edema. Could be mesenteric fat. Could be subcutaneous fat. What else? Gas, right? Gaseous distension. So take your cirrhotic. We give them lactulose, so they have gas. They may have ascites. They may have they're going to have some fat, right? So everybody has some combination of those things. So, okay, where should we poke these patients? These are all calls to our procedure service, by the way. So how about this one? Where should we poke him? He's got some stretch marks, looks pretty distended to me. How about this one? Pretty distended too. This guy looks like somebody tried to poke over here before they're calling us. So, maybe we shouldn't go there. How about this guy? He's pretty thin. He doesn't have bulging flanks. Well, let's see what we find behind each of these windows. So this one, does he have ascites? He sure does. Should we poke him there? Not really, right? Not today. How about this guy? This is a great case. So this was actually, we did this one under real-time guidance. So we used the needle and we just recorded, and you can see the bowel here. We just snuck the needle in under the peritoneal lining, took the sample out. And we were so glad we did because this patient had 5,000 white cells. And so over the next several hours, all his cultures turned positive, came in with vague symptoms. But when we saw 5,000 white cells, we put him on broad spectrum antibiotics, right? But think about his typical course. He would have come in, would have sat on the floor. Maybe we don't need to tap him, maybe not. Well, let's just watch him. He's in for obs. He would have ended up in the ICU, probably would have spiraled down, right? Being a cirrhotic. But instead, we treated him aggressively up front, and he actually walked out of the hospital. How about number 3? What do you see there? Septations, right? Can you see septations in loculated ascites? For sure you can. Not as common as up in the chest, but what's the important point here? A short course of antibiotics isn't going to clear this person's infection, so they're going to need a longer course and follow up in the clinic. So the one that was the easiest to tap though of all these was the thin guy, the far right image here, where, okay, there's a nice pocket here, and we could do a drainage. So all these patients, they could look very simple, just go stick this big, 6 French, 8 French harpoon into the belly, but you don't know what you're poking into unless you look first. This is one of my favorite ones. So this was a patient, you look at this belly, he's got a scar here, he's got a scar here. Somebody tried to tap him over here. And then when we looked, we saw he has a lot of ascites, but he's also got a clump of small bowel that's adhered to the abdominal wall. He previously had a drain in. And so this causes adhesion of the mesentery to the abdominal wall. So what could happen? All of you can imagine what could happen, right? You could put that 8 harpoon in through here and then poke into the bowel. So look before you poke. So benefits of ultrasound for paracentesis best shown in pictures. We can quantify, characterize ascites, know exactly where we want to put the needle, and we can avoid abdominal wall vessels. So if you're doing paracentesis, please do the 2-probe technique. Use a low-frequency probe, find the biggest pocket, switch over to linear probe. You can measure the depth, put some color flow Doppler on, tilt in both directions, put it on a low flow setting, make sure there's not some big vessels flashing at you. About 10% of cases, there's a review on this from quite a while ago from Jeff Barsick in Chicago. And I believe it, if you do a lot of these, eventually you'll say, ooh, I'm so glad we didn't go there. I'm just going to slide a couple centimeters over and avoid those vessels. And then if it's a small pocket and it's clinically indicated, you can do this with real-time guidance. Same ways you do IJs or any other joint injections. Just track the needle tip. This is the $1 million skill. All of you can learn to do this. It's really not rocket science. It's a very manual, hands-on skill. So this one was read as a moderate right pleural effusion, but what's our differential here? Could be consolidation, could be fluid, could be an elevated diaphragm. This ended up being an elevated hemidiaphragm. So you get your answer within seconds by putting the probe on the body. So for pleural effusions, we can do a lot of things here too. We can characterize the fluid, and then we can put it into categories of simple, complex, septated, and in some cases we'll even see bubbles in there and actual frank pus that's floating. And then if you're going to do the drainage procedure, you just get more data. If you're supervising trainees, okay, it's going to take us this much depth to get into the chest wall, so I should be getting some fluid back after so many centimeters, and we definitely don't want to go more than 6 or 7 centimeters in, because we're going to start hitting lung. So if you're supervising and somebody's advancing the needle, you say, well, wait a second, we should be getting fluid by now. Let's reassess. This is a rib here, and this is the pleural line. And this is a nice little collateral arterial branch on the superior aspect of the rib. So you can pull it up on your phones, Google this. There's collaterals that live on the superior aspect of the rib. Some of you say, hey, that's not fair. I learned you hit the rib and you go over it. Well, patients don't read the textbooks. This actually was one of our faculty members in a workshop, and he just volunteered his chest, and we put some color on. He had a big, arterial branch sitting on top of the rib. So you can imagine what can happen here, right? And this happens everywhere. Procedure goes well, and then the procedural says, I don't know why they bled on me. Went right over the rib. It was smooth. It got bloody towards the end. Well, it's because there are these collaterals that live up there. So we can check this. Not as common as paracentesis, but for thoras, it does change your site selection every now and then. So what would you do in this case? Well, you're not going to go under the rib. You're going to just go right in between. Mark it correctly. Build your confidence. Say, okay, if this is my probe and this is my needle, I'm going to go straight through here. I'm going to go through these tissues. Okay, I'm going to follow my needle. Okay, good. Patient hasn't moved. I know my angle. I memorized the angle I'm going to go in. I'm just going to mimic that angle now with my needle and go straight in, draw back, and do the procedure. This is a chest wall mass, and I didn't put the original image, but when you look at this patient in the depth, there's this huge effusion, and at the very, very top, there's this stuff on the chest wall. So when you check with the linear probe, this is what you see, and you realize, well, there's these big, juicy metastases on the chest wall. And unless your intention is to do a biopsy, you can just avoid these and avoid kind of the bloody mess. I mentioned skin and soft tissues a little earlier. So here on the left, we've got classic cellulitis, cobblestoning. These are just subcutaneous globules of fat with edema. So all this little black is just regular cellulitis without an abscess. And then you see this one on the right, and there's a nice little abscess pocket right here. right? And we're pressing down with the probe and you can see this fluid moving back and forth. So this is a small subcutaneous abscess that needs to be drained. We're only at 2.7 centimeters here of depth. So this is small, right? So this is something you could drain in the clinic, but it gives you more data. This is a patient that came in, usually gets a course of antibiotics. He said every now and then he'll get these subcutaneous abscesses or cellulitis, and then he had a small abscess this time that needed to be drained. Simple stuff, but easy to do at the bedside. POCUS never events, the never misses. You know, I think these exist, so I'm not trying to insult anybody's intelligence, but you know, these patients do walk in with huge effusions like this. May not have this crashing and burning appearance. They may just be like, hey, I'm feeling short of breath, and they built up this effusion over months. And then severe LV systolic dysfunction. You know, take a quick look, especially if somebody comes in with syncope. I had a syncope recently, low risk, gonna send him home. Still a little bit dizzy when he stood up, got some IV fluids. To put a probe on his EF was like 10 to 15%. So he stayed in, didn't discharge, and went to the cardiology service and got a workup. So we can avoid those misses. And this was just a case, you know, I'll just show this to you real quick. I don't have the images. It was a recent case, but the way it's documented is documented very nicely, even without seeing the images. Patient came in, had sinus tachycardia in the 120s, fever of unknown origin, hypotension, very, very common picture. And then they said, you know, POCUS showed severely reduced EF. Most recent echo showed normal EF, so something's changed. And then they had these other abnormalities, had some signs of pulmonary edema, CTP protocol without a PE. And then, you know, it's written, this picture is concerning for a shock, likely cardiogenic, secondary to NSTEMI type 1. So this is what you can do with POCUS, right? And this is how it can be written. You do have archiving systems in place, and we can talk about that towards the end, but this is how it's being integrated into care. So switching gears, talking a little bit about training. So what are the big barriers to point of care ultrasound use? So hopefully I sold you on the idea that, okay, we need better diagnostic tools and I want to start using POCUS. Why are we not all using it? Number one and number two switched recently. So it used to be access to machines. Early on, people just didn't have access to machines. Now we have access to machines. They're all over. And now we need training. And that's actually been the big barrier. We've seen this on the VA system, we've seen it. In the non-VA system, we've seen it. Once you get a machine, you need training. And this goes across pretty much all specialties, even in emergency medicine, where it's been integrated into ACGME requirements, which I'll show you here in a little bit. I think physician inertia it's less and less. And then we have, you know, institutional things around archiving and documentation, which there are solutions for. So number one barrier, top barriers is training. So how do you train people? This is really no different than any other clinical skills people learn. You need some basic knowledge. You need some image acquisition practice, some image interpretation practice, and then clinical integration. So all of you are doing clinical integration every day. You get a bunch of data points and you make a decision. So now you have one more data point. The area that takes a lot of commitment here is going to be image acquisition, and then secondarily, image interpretation. Image interpretation is the cognitive piece. For those of you that are supervising trainees who maybe you're close to retirement and you say, hey, I'm never going to become a master of actually acquiring images. Well, you can become a master, at least of interpreting them and understanding what you're seeing on the screen so you can supervise your trainees appropriately. So there's a lot of different training pathways. There's the ACGME residency fellowship pathway, and then the practice-based pathway, which is where most of us fall who are learning this through CME. But I do want to mention the residency and fellowship pathway. So all these different specialties I've listed require some amount of ultrasound training. I put family medicine in yellow because that's a recent one. Internal medicine is not on the list. If you read the ACGME guidelines, they talk about point of care diagnostics. They mention ultrasound a few times. They even put it in a little box off to the side as an example of point of care diagnostics you can use. But eventually, if anything, it's going to come into there. I think that you at least have a working knowledge or some familiarity around ultrasound. I mean, we require, you know, the procedures that are required, I think, are still Pap smears, peripheral IVs. I mean, and you say like, we're requiring these things. We need to at least require some basic ultrasound knowledge. So I think it's just a matter of time before that happens. Having said that, internal medicine programs that have ultrasound training, it's a huge recruitment tool. and they're the most popular electives around the country. So I think, there's other benefits without having to have the ACGME telling us what to do. There are also these one-year POCUS fellowships. So a lot of these were emergency medicine fellowships, which have now been opened up to family medicine and internal medicine and other clinicians. And so they're taking non-EM docs. I want to mention a little bit about medical schools and residency before I go back to the CME pathway. But there is literature around this. There's been a lot of work around this. Ohio State, South Carolina, UC Irvine, they publish a lot of their curricula. They're out there. It's also, again, another recruitment tool, very popular amongst the medical students. And probably there's got to be some fine balance between traditional physical exam teaching and then integrating ultrasound with that. Right? This is our ultrasound center. Medical students love it. This actually got funded through the dean's office, and it's become an institutional resource. It's anybody can use it for the fellows, the residents, the faculty, students have priority. But it was it's been a great investment from an institutional standpoint, and we've used it for all kinds of events. There's also an educational discount you can get on devices. So when you're doing this, if you are going to buy equipment for a simulation center or an ultrasound center, make sure you get the educational discount. Moving on to internal medicine residency, there are some guidelines here. I would say the AAIM has put out some papers. There's also this one, which is actually not published just yet. This is a really busy slide, but just to show you, this was a consensus-based project. It'll be coming out in American Journal of Medicine. And there's the wheel of POCUS right here, where you have the indications and then which applications you would use. And then this is a breakdown of all the different potential applications. It'll be coming out pretty soon. So the students are learning this. I think based on the literature, it's at least 60%, probably even higher now. Internal medicine residents and other residents are learning this. Trainees are learning this. Critical care fellows are learning it, et cetera. It's been a requirement in emergency medicine for a long time. Internal medicine, as far as our best we know from the Aptum survey in 2020, was around 61% of programs. So they're all learning. What about the faculty, right? And this is kind of the difficult part. How are faculty getting trained? So what's the average age of docs in the US? Do you know? Anybody know? Anybody want to guess? 45? Flip it. 54. It's about 54, right? So the vast majority of us started practice long before this was even available. So how can we get trained? You can have internal intramural training, which is here actually. I put you've developed, Dr. Hegazi and colleagues have developed a very nice POCUS Academy. So hats off to you. It's a great multi-specialty collaboration. So internal programs you can build once there's been an investment in time and resources. You can do this. I put some other examples of other institutions that have also done this and done it well. And this is probably the best option for training the faculty. And you can have slow, steady growth and investment in this area, and then it trickles down to all the trainees. And then the training is the same training pyramid I showed before. So you need to have some part of all these different components in there. Extramural training. So let's say you're at an institution that doesn't have any of these things available. How can you get trained? I want to mention there's no board certification in POCUS. It sounds like a good idea, but when you try to operationalize it, doesn't go too well. How many of you want to have more board exams, more password resets, more logins, more maintenance certification, right? The whole national board system has come under scrutiny. So it sounds like a good idea, but there is a national board. There's not a national board, and probably there won't be one. I heard National Board of Echo may be developing one. The question is then who's going to sign up for that, because it's coming through primarily a cardiology organization. So to be determined. There's the APCA pathway through the sonography organization, which has not taken off. So I don't know if it's gonna take off. I think just like so many things we have to police ourselves. And if anything, you ask yourself, well, how comfortable am I doing this, and should I be doing this? Just no different than anything else, whether it's reading EKGs or looking at X-rays or diagnosing somebody with a certain disease. I do want to mention emergency medicine started a focused practice designation. And so their thought was maybe other boards will come and do this too. So maybe internal medicine will do this, maybe family medicine will do this. And they started that in 2022. For cardiology and for cardiac imaging, National Board of Echo historically always only offered a testimonial status. So you could take the exam and say, hey, I took the written exam, but I can't get board certified because I didn't do advanced cardiac training. Since 2019, they've offered this advanced critical care echo board, as long as you take care of critically ill patients, which is loosely defined, and you do 150 echoes, get that are signed off by somebody, you can sit for this exam and get boarded by the National Board of Echo. Again, it's another board exam, so it comes with them main certification and all the usual password resets and things like that. And then there are training certificates. So we have one through the Society of Hospital Medicine in collaboration with CHEST, and then CHEST started with their critical care ultrasound certificate in the mid 2000s. This is the APCA pathway that I mentioned, which just hasn't taken off. It hasn't been very popular. This is the SHM CHEST collaboration that we have. I'll skip through this. If you're interested, you can go to the website. It basically has the same components, some knowledge component, some hands-on scanning component, a portfolio you have to make, and then do some final skills assessment. Talking a little bit about privileging, I just want to give a few nuggets here. Going back to the late 1990s, like 1999, this is what was said. The AMA said ultrasound imaging is within the scope of practice of appropriately trained physicians. So it didn't specify one specialty. And essentially, everybody owns ultrasound, right? There's very few specialties that don't use it now. And if anything, everyone goes to medical school and basic training to where they're going to get exposed to it. A couple controversies and challenges around credentialing and privileging. So what do you call it when imaging specialists, radiologists, cardiologists, obstetricians do their own ultrasounds, right? They say, well, hey, we interpret these, we prepare but we don't scan all day. So there's even a separate category called like expert focus for American Society of Echo had this written in. So if a cardiologist is doing it, it's a separate category. What about non-imaging specialists that are advanced users? So this best example here, critical care doc who's doing lots of echoes all day, maybe even doing TEE, versus the electrophysiologist who's a cardiologist, but spends her whole day in the EP lab and is not looking at echoes all day. So who's better qualified here now to be talking about echoes? Probably the person that does them every day. What about patients' use of ultrasound? I'll mention that at the end. A few other nuggets around credentialing. Should specialists that perform more invasive procedures be allowed to perform less invasive procedures without ultrasound? So, we had once a surgeon got very angry and said, I don't need that little tool. Take it out of here. I can take the neck apart if I need to. If I hit the carotid, I could fix it. Okay, you can, but is that the right thing that we should be doing? Or are we going to set a deadline and say, hey, January 1st, 2026, every central line that goes in needs to be done under ultrasound guidance, except here's some caveats when you may not know how to use ultrasound, right? And you're going to have to take people's privileges away. It's going to be kind of an ugly argument from a patient safety standpoint, and what society would say, the community would say, oh, yeah, well, we want our healthcare to be safe. So, but we had to break away from some traditions here. Traditional scopes of practice are blurred by ultrasound. So, and the best example here is 5 o'clock hits, 6 o'clock hits, and NPs and PAs around the hospitals, like the ICUs around the country. So they can put in lines and chest tubes and do whatever. But between 8 and 5, no. You little measly internists, you better call us, subspecialists. We're the qualified ones to do these things. You guys can't do it. So, hey, help me understand the difference. Well, maybe we can say everybody, when they have better tools and they're trained appropriately, they can do all these things safely, right? At the end of the day, medicine's a team sport. We need everybody. It's not about you're right and I'm wrong. It's about taking care of patients. And then there's a separate credential needed for those who have gone through all these training pathways. So for all of our new graduates, they're like, hey, I got this medical school. I got it in residency. I got it in fellowship. Like, why are you investing so much time and energy into all this credentialing stuff? And eventually we're still in this era where we feel like there needs to be a separate credential, but eventually it's gonna become a part and bundled with just people's basic privileges. There are some documents around this. This is for hospitalists and internal medicine, but there's similar documents for critical care, emergency medicine, et cetera. I wanted to show this one slide just because it takes a village. And so this is, big investment from the institutions. Once you start using ultrasound, everybody comes to you and says, hey, we need training. And oh, by the way, we're missing the machine. Oh, and what about this? Oh, the probe is broken on that one. Like it takes a lot of people involved, it takes an investment. But again, there's a benefit for the whole health system. Funding for POCUS, this is a busy slide. There's a lot of different opportunities. I just want to mention a couple of things. I want to talk about clinical revenue, research opportunities that are out there, and then education we talked about, which I'm not going to go back to, but there's different ways of spinning this depending upon UME, GME, or CME. For billing, there's very specific requirements. You could look these up, talk to your billing people. There's always an educational component, not just for us, but for the billing people too. Once you start sending new billing codes in, they get nervous. So they may not actually submit your bills, and then you educate them, you talk about it, how are we interpreting Medicare guidelines, and then you can start billing. But you basically got to have some documentation and some images archived. I updated this slide. Unfortunately, this column here on the right, the numbers have gone down. They used to be like 89 and 16, and now it's like 84 and 14. But there is some revenue that can be collected here. Again, we also feel like once you've documented and billed, you've sort of bought the responsibility of that exam. So some people don't want to go down this pathway because they don't feel like they did enough, complete enough of an evaluation. And again, then they're using it like an extension of the bedside physical exam. I think, that one thing to take home is, we're talking about roughly $30 on the pro fee side and roughly like $100. But reimbursement isn't the biggest driver. This is an EM paper where if you look at the blue here, these are all the board certified emergency medicine doctors. And so most of these have had training during their residency. And then you look at who's actually billing, and you look at these little pockets around the country where there's actually a fair amount of billing. I've always wondered about these people in West Texas. I'm like, there's this county in West Texas, somebody's raking in some money there. Research opportunities, health sciences research, or health services research, I should say, there's a lot around patient safety, quality improvement. But there's also collaborations for clinical and basic science research. So for those of you who have these partnerships and are interested, jump in there. It's just one more diagnostic marker. So, we did this project with their critical care doc. So I was the ultrasound guy, and I did cardiac ultrasounds and lungs on baboons, and I didn't know all the other data. It's got this big baboon and who's anesthetized, and you're like, I hope he doesn't wake up. Hope he doesn't wake up. Let me just get this done quickly. Well, but yeah, scanning. And this was kind of the neat thing is that, so we looked at our ultrasound images, and then they actually correlated them with the postmortem, the pathology slide. So, fun project to do. So look for these opportunities. They're out there, and even collaborating with the veterinary side. Last couple of slides about the future of POCUS. So the technology keeps getting better. We have these ultra high frequency probes for dermatology, superficial image. You can get great images. Think about it. For how do you like skin cancers? Well, you got a basal cell, we're going to take it off. Well, how deep is it? What's all around there? And so historically, dermatologists haven't had access to this. Well, now they have access to better tools too. They can make decisions. Many times it's a very basic decision. Do we need to get plastic surgery involved or not? Is it invading the bone or not? Can we do this at the bedside? Does a clinician, she or he, feel comfortable doing this at the bedside? And then there are these hybrid transducers that are coming out. This is a linear probe, but it can go down and you can look at kidneys and deeper organs, bowels, for example. It's a whole world of intestinal ultrasound. Needle visualization technology for either in plane or out of plane or longitudinal transverse approach. There's software. You may even have these on your machines. So check it out. If you're buying new equipment, get the software upgrades. It may be $1,000, $2,000 more. When you're buying a $50,000 machine, it's not that much more. But this will help steer the ultrasound beam to light up your needle tip. So most machines, they have this for longitudinal plane, but there's also some for a transverse plane. So here, the machine is telling us, that you're in the green or you're in the red, and you can't see the tip. But it has some kind of indicator to help you in a transverse plane. There's a couple of different softwares like this that are out there. Teleultrasound, so we can use this for training. We can also use it for clinical care. This is actually how we did the training with many of you back in the pandemic. We did it over teleultrasound. So our faculty were in California and Texas and Midwest, and they were connecting with learners online. And here's the faculty, they have two markers. Here's the person scanning, and you can see you're getting a screen share there. This can also be used for patient care. Hasn't been used very well here in the US. This is actually from China, but this goes back even probably about 10 years, where you have somebody on call in this part of the country looking at an ICU image from somebody on the other side of the country. Pretty cool, right? And we can do this across systems. He can be right there at the bedside. So if you could be at home and let's say it's an ICU fellow who's there and they could, you could log in and be like, hey, let me help coach you through this, and we can make some decisions. Last couple of things here around artificial intelligence. This is an area that's exploding faster than we know what to do with. So key points here for training, you can use AI, and I think this is a safe use of it. So you can say, hey, take this device, go practice, go do 10, 20, 50 exams, and the machine will coach you through. So here you're getting an apical 4-chamber view. When you get a 5, the machine is saying you're getting a high quality view. This one, there's another indicator where it turns green. And at the same time, it's doing an auto EF calculation, okay? This one here is showing you how to turn the probe, and it gives you some directional information. It says, rotate, hold for recording. So even as you're scanning and going through, you're seeing it, you don't see it, the machine is already gathering data and interpreting it for you. So that's the acquisition piece, and then this is the interpretation piece. So while you're sliding around, the machine is already taking all that data and can calculate the EFs, stroke volumes, labeling here. The machine can detect this. Auto strain, this is out there. Really subtle findings for LV dysfunction being used more in the critical care setting. The data is kind of scary good. If you get a quality image, like the best fit line is straight across. There's just not a lot of variation. The machines don't get tired. They don't need coffee. They don't need to go to the bathroom. Last couple of things here, patient care or patient use of ultrasound. This isn't anything new. There's even some papers around this from COVID times. Could you do remote tele-ultrasound and have patient data? So if you have, let's say, advanced heart failure patients, you're here in upstate New York, you have patients that say, hey, I live out on a farm, I want to live there, I want to die there, but you're managing them from a distance. Well, maybe they can send their data back, and before they end up volume overloaded in the ER, you could catch them, maybe tweak their diuretics and make other adjustments from home. Home-based primary care is another great opportunity. Palliative care, home-based, palliative care is another big opportunity. So take-home messages, ultrasound, bedside tool available to all of us, including patients. Training is the #1 barrier. So this is where our investment needs to be. For clinicians in practice, there's a practice-based pathways, internal pathways like the one you have here, your POCUS Academy. There's lots of external pathways through national societies. And then it takes a village. You need lots of people involved. And that is it. Thank you, everybody, for joining. And if you get tired of, there's a whole world of veterinary ultrasound. It's a lot of fun. Dogs have really wide rib spaces, so you can see their entire heart. So if you get tired of humans and you want some warm time with a furry animal, you can join one of the veterinary POCUS workshops. All right. What questions do you have? And let me open up the chat. Go ahead.
Outstanding. Thank you very much. So your institution, did the institution provide the devices for students and trainees, or was there an expectation that they provided for themselves? How did that play out?
Yeah, question on institutions providing devices for trainees. We've slowly accumulated them, mostly handhelds. There's an assignment process to track them. We've done pretty good about not losing them. Some institutions have given them all to all their new medical students and trainees. You may be able to pull this off on an educational grant through one of these companies, and then they usually want to get feedback. But at my shop, it's generally, we've slowly accumulated these. You can buy used devices, loaner devices. They're at a discounted price. You can buy them personally. You can buy them for the institution. There's educational discounts. So that's kind of how we've done it. And I think tracking them is the biggest thing. That's sort of, I think you have a good system here, but it's nice to say, assign it to somebody or assign it to a service or a team, and then it's kept, track of, especially the handhelds. 2,000, 3,000, 4,000 is kind of where they sit. Go ahead.
Residents here, LVDF and said,
Yeah.
How can we manage, with all the billing? And now CMS is removing echo 90 with the billing patterns. So this is takes time. How can we manage all?
Yeah, no, it's a great point. And I think most places have seen, once you start doing these bedside echoes, the TTE ordering goes even higher. And then hopefully we have, there should be maybe a decline, but I think one way would be if those images get the question answered and they can be shared. And if somebody wants to get a sign off or an overread from an imaging specialist, then that could be available through the platform. And then it's really the sonographers. We don't have enough echocardiographers and sonographers, and they're getting paid overtime or they burn out and they go elsewhere. So that's another, issue. If we can share those images and then you as a cardiologist say, well, what's the question? The EF is 25%, and that's what you guys are seeing. And do we need to do more? They already had a comprehensive 6 months ago or a year ago. They're coming back. Then we could maybe reduce that. So I think it's going to be this communication. It's more of in the system. If those images can be archived and shared, and they're good enough quality. Now you may say, well, that's just a really bad image. I can't even interpret that. I don't know what that. So, and in those cases, you do have to get another, full echo. But I do think there's even a paper I know of one that showed there was an increase in echoes ordered once people started integrating this. I think if we just have started looking at this more from a system standpoint, we're still sort of stuck in this fee-for-service era. Even when I was a medical student and college student, there, people were saying, oh, fee-for-service is dead. We just haven't scheduled the funeral. But still, 30 years later, we're stuck in that. Any other questions, comments? And again, we've been, go ahead. But yeah, for quality assurance, that's a great, so quality assurance being for those who are credentialed and have proven that they can do this, are we going to go back and check on their images? So I think when people are getting credentials, there's maybe a provisional period where they're looked upon more closely, but then afterwards, there's a couple of institutional examples. So Benji Matthews and the Health Partners Group out of Minneapolis have published this, but then they take a sample and they review their images. So any negative cases, sentinel cases, bad outcomes should get reviewed by a group, multidisciplinary group, cardiology, surgery, medicine, et cetera. So we can learn what went wrong. And then periodically checking people's images, taking a sample when they're up for re-credentialing, making sure they're following the rules that have been established by the organization. It's a big investment in time, but I think the platforms exist and it's just a matter of us doing work. 10% are reviewed. So for those who have credentials, when they're going for re-credentialing or periodically once a year, whenever you're taking 10% and looking at them. Yeah. What other questions do you have? Go ahead.
So then you are starting with the step any challenges?
When we were starting POCUS way back in the early days. And say it again, what was your question about challenges? How do we overcome getting good images? So that's an important point. Acquisition is where we lag. So garbage in, garbage out. You got to have a quality view. And that's where we really have to practice, do a lot of scans. I think in the early days, it was this communication between specialties and understanding how we're using it. We're also trying to triage patients. So instead of ordering the echo, CTPE, CT, MRI, we can just get the 1 or 2 exams that we need. But I think the best way to learn is to scan, right? And then you also learn your limitations. I think it's almost like the more you learn how things are, how complicated things are, right? You can get into, cardiac valves. So sure, we shouldn't miss a huge regurgitant lesion in somebody's home that's never been worked up. But at the same time, there's a lot of structures around there that you're not going to be able to evaluate. So I think my recommendation would be just scan. And for trainees that are out there, and if you have trainees running wild with probes, and they're not getting supervised, have them scan patients that are going to be getting the gold standard exam. So if they're going to be getting a CT chest, they can go and scan. They're going to be getting a comprehensive echo, they can go practice there, and then they can compare their exam to the gold standard exam. And you'll find discrepancies. And this isn't about pointing out people's errors. I mean, we even recently had one for a DVT scan. 4 extremities or negative, but then the fellow had found a clot up here in the IJ. And so we called the sonographer back and said, hey, could you look? Oh yeah, there's a clot there. So it's just mainly they were called back for documentation purposes. And then, another report was submitted. So again, it's a team sport. And if you can give I'd say like the echo lab and your cardiology colleagues and radiology colleagues more information, it would help them in answering the questions. I don't know if I answered your question though, but I think that the biggest challenges initially were breaking away from the inertia that we're going to do things differently. I was fortunate to have cardiology colleagues, radiology colleagues that were good mentors and helped along the way. So grateful for that. Any other questions or comments? Let me open up this chat. Could you speak for a minute on what we need to know about medical legal liability and implications for bedside ultrasound? Yeah, I think this is for medical legal liability, document what you did and document with caveats. So patients want to hear everything looks great, right? But you want to say, no, we did a limited exam to evaluate for pericardial effusion, and there was no large pericardial effusion, comprehensive echo to be done or was already done recently. I actually think it's protected from a medical legal standpoint. You won't miss the obvious. One of the cases I had that made me a believer was a AAA, and the patient was in the back room and it was rupturing, and that patient's trajectory would have been go to the CT scanner, probably code when they lifted him and dropped him, and it was like 9.5 centimeters. Instead, we pulled him to the front, put him in Trendelenburg, and he went to the OR and he survived. But like those are the ones I think are the great saves. Another question: are there upcoming areas of research and POCUS you're particularly excited about? Oh wow, yeah. And the reason I got so much in education was to eventually get to the research. So I think from a system standpoint, that's the kind of data we need now, and multi-site data. So really about the utilization and the cost. It's not the romantic stuff of, hey, we discovered a new protein or new DNA, but I think that's really where we need to go. Because from a system standpoint, if we have a finite number of dollars, if we can get people through the system for the same diagnosis with less cost, then we should be better, right? Even though all the drivers are not aligned as we would like them to be. And then, do you think POCUS certification will become a must-have for hospitalists in the near future? That's a good question. I think you're going to need to have a working knowledge, especially if you're going to supervise trainees, because the residents are, I'd say, almost always right when they're using ultrasound. I mean, when they're looking for effusions and things, they see it and it makes the faculty uncomfortable. So I think you are going to need to have that if you're in a teaching setting. I think the few basic ones I showed up there that were like the must knows, that might be what you would need to know at a minimum. What other questions or comments do you have? And feel free, anybody who's online, to unmute and speak. Any other questions? Go ahead.
I have a question about the documentation. I think most of us who use POCUS at bedside would probably point one line that, we saw like D-line or something. What do you recommend? How document their pointing, how much detail?
So if you're doing a separate exam, you can have templates created in Epic, and POCUS lung, POCUS cardiac, or whatever, however you want to label them. And then those can be linked over to the images and the PACS or the server. And then they could be billed, right? But if you're just doing this sort of extension of the physical exam, you can actually document it within your progress note. And then you can put it into there. Yeah, but I would recommend a separate note, especially for a variety of reasons. And then for credentialing and QA, it's easy to find. But again, I would say document what you did and what you saw and what you actually looked at, right? So, you don't want to put a bunch of negative stuff that you actually didn't evaluate. Yeah. What other questions, comments? Well, thank you, everybody. Oh, go ahead.
Why don't you go up, just so we're way past?
Oh, sorry.
Why don't we- no, 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 no. But if anybody else has questions, go right up and talk to her.
Yeah, thank you, everybody, for your attention. Thanks for staying. I'll be up here. Thanks, Zach. Oh, yeah, thanks, Zach. Hey.
Hi, Alex, one of the chiefs here.